a little bit different for ortho, right? Make sure you understand that concept because when I precept, right, been doing it for almost 2 decades now, and a student would come to me, I would be like, what do they do for a living? How did they injure themselves? Was this in cold weather? Was this in water? Was this, remember we talked about temporal factors? Okay, do you think arthritis, do you think people that have arthritis complain about more pain when it's cold? Yes, the people that have arthritis, I'll raise my hand, don't raise your hand. But, you know, they know that on cold mornings it hurts a little bit more. So that's an example of a temporal factor. So history can tell you a lot from orthopedics. So if you don't get a good history, you're behind the game. Make sense? So what are you going to do? You're going to do an exam on the entire body to figure out what's going on? No, you're going to get a good history, and you're going to do a physical based on their chief complaint. Make sense? They have shoulder pain. Might you do an elbow exam as well? Sure. But at least you're not doing a knee exam, for example. Right? You're not shooting in all directions. Does that make sense? So make sure you spend some time looking at that. And don't worry, you'll get into that in clinical, right? Fracture evaluation and management, that's something I added. I told you guys that it didn't used to exist. Right? But I figured I would give you a little primer into what's an open, closed, what other fractures that you need to know about. Because then you get into block 4, and it gets thrown in the middle of foot and ankle. So it can be a little overwhelming. You're like, wait, whoa, whoa, whoa. We're going back to upper extremity fractures? Yes, you will, okay? But then you're talking about specific fractures. It's not just open book, right? Specific fractures, but at least if you have a little primer, which is what I try to give you, you're not like, oh, I never heard this before. Make sense? I tried to give you guys the topic once, twice, and then reinforce it in the lab, hopefully, right? So you'll hear multiple topics, multiple subjects I think are important for you to know, not just to pass this course, right? But to be providers. I want to make you guys providers, right? Confident providers. So I will give you a little pearls, if you will, every now and then. I'll try to make sure I tell you if they're testable or not, okay? I have my biases, don't judge me. Okay, operative versus non-operative, we understand the differences, right? You do understand as well that if you send a patient to orthopedic surgery, right, to me, if you tell the patient that I'm going to talk to him about surgery, and then the patient sees me and I talk to him about non-operative care, I'm going to send him back to you to talk about what surgery you recommend. Does that make sense? So don't promise the patient surgery. Okay? Let us decide if the patient needs surgery. Just tell them they have a consult with us, and it's okay to tell them what you discussed with us, right? All right? Don't promise things you can't deliver. I'll find you. Okay? That's a joke, sort of. Okay, so NSAIDs, you guys probably have a primer to NSAIDs. You'll get into pharmacology a little bit more. But you understand that corticosteroid injections are not for everybody, right? All right, we'll get into that a little bit more. I try to break it down into the specific pathology and diagnoses so you guys have a sense of, with this particular pathology, you consider this versus this, the other pathology. Yesterday, again, was just broad strokes. The real first topic that we discussed was osteoarthritis. You need to know osteoarthritis. You're going to see it a lot, okay? Whether they're young, airmen, soldiers, Marines, sailors, coasties, I guess. I got to throw that in there. You know, they may have osteoarthritis or they may not, right? Usually if they're young, they have post-traumatic osteoarthritis, correct? Okay, so you're asking for a history of what? Trauma, okay? Injury, fall on outstretched hand, some kind of injury maybe they were or were not seen for. And then if you're just talking about old dudes like me, it's usually primary osteoarthritis, right? But don't forget the loss. The loss applies for all osteoarthritis, right? LOSS. Remember I gave you guys that? Okay, loss of joint space, osteophytes, spurs, what? Sclerosis, and subchondral cystic formations, okay? Those last two, you'll more so see a lot more on x-ray, right? Okay, but you can see, I talked a little bit yesterday about knee osteoarthritis. You can see a collapse of the medial compartment and suspect that they have the L, correct? That may be something you can visually see, okay? Can't see the osteophytes either, but you'll see them on x-ray, okay? Any questions about what we discussed yesterday? Okay, my goal is not to burn through the slides and then you guys come back and you're like, I don't even know what we discussed. We will hit topics and we'll hit them again as we need to and do a review like I just did. Every single course, every single period of instruction, okay? Hopefully you guys find that more helpful than spending another 10 minutes doing a quiz that nobody really cares about. Okay? What did I replace that with? I told you guys, when we get close to the test, I'll give you sample test questions. And that's not meant for test compromise. That's not meant for test whatever. That's meant to get you in that mindset that, hey, he's going to ask me a question like this, so I should study like that. Good to go? Okay? You know, questions are going to be different, guys. It's not going to be straightforward questions. You guys understand the difference between a first order, second order, third order question? Okay, I'll give you an example yesterday. All right, of a third order question. It's one where I will give you a patient presentation, I will give you a radiographic finding, I will give you a physical exam, I will assume that you have made the diagnosis, but now I will ask you the treatment. That sounds pretty intricate, huh? But that is a third order question, if not a fourth order question, depending on how you look at it, right? Because that assumes that you know the knowledge to get to the point where you can answer that question. Okay? Is that good to go? Okay. So if you guys are utilizing previous study guides, again, I'm not asking, you're not telling, right? But be careful with that, because again, I'm going to prepare you for what you're going to see, what you're going to experience in this course. And ultimately, you guys understand that I care more about you guys passing pants as well, right? I really do. Okay? Your ability to navigate my course is one thing, I just need you to become senior, right? But your ability to pass pants means, do you start seeing patients or not, right? Are you a licensed, credentialed, certified PA? Okay, so I'll try to prepare you for that as well. Good to go? Okay, without further ado, excuse me. Any questions before we get started? No? Okay, all right, we'll get started. Questions? Question mark? So, welcome to lecture 2. So now we'll start talking about systemic pathology. I want you guys to focus on the fact that it says systemic, right? Because yesterday we talked about how osteoarthritis is not systemic, correct? It is a progressive degenerative process. But systemic means there's something going on throughout the body, right? Some kind of disease process is being initiated due to some kind of underlying etiology and pathology, okay? So the first topic we discussed is rheumatoid arthritis, okay? Have you guys had rheumatoid arthritis already? A little bit? Okay, that's fair. Okay, I've looked at the slides that I was given that said it was taught in some other course. Just to be clear, rheumatoid arthritis, does orthopedics necessarily treat rheumatoid arthritis? No. You guys know that there's a specialty called rheumatology, correct? But since it's near a bone, joint, things like that involving them, it gets stored into my course as well. I'll do an adequate job, hopefully, of teaching you guys what you need to know. But just understand that you may get more instruction on it in other courses because it more so belongs in other courses. So going along with that, the seronegative spondyloarthropathies, okay? So seronegative, what's sero mean? Serum, blood, right? We're taking the blood, we're spinning it down, we're testing serum, right? Just that simple, okay? So we're going to get into some lab stuff, okay? Compartment syndrome, that is orthopedics, okay? We'll get into that. Complex regional pain syndrome, you're going to find that that's somewhat orthopedics, but that's really multi-factorial, and it requires a more multi-specialty approach, okay? It's not a fun diagnosis, but we'll go through it. CPPD, or crystalline deposition disease, that's things like gout, pseudo-gout. You guys have had that, I know that. Okay, but I'll go through the labs again with you guys. Okay, we'll go through that stuff. Okay, and then DVT. Is DVT an ortho thing? Not necessarily. I know you guys are going to talk about pulmonary pulmonology because I've seen this slide deck. Right? I'll give you my take on it. Okay. So getting right into it, rheumatoid arthritis. So rheumatoid arthritis, what is it? I need you guys to understand this is a systemic autoimmune disorder. Okay. So what I'm going to tell you right now, right, I'm going to get right to it this semester. Meaning, if it's systemic autoimmune, do you think it's better to treat symptoms or to treat the underlying autoimmune process? The process, correct? So when you're studying the medications and you get into pharmacology, understand which is which, and I'll go through those with you, okay? That can be acute or chronic synovial inflammation. What is the synovium? That's the lining of the joint capsule, correct? Okay, so that's what we're talking about. So this is involving joints in my stories and my course as well. Okay, there can be excess synovium, means that there's a proliferation of the synovium itself, and these erosions where the joint capsule meets the bone. Okay, so it's an erosive process. So what do you think you're going to see on radiographs? You think you're going to see erosive lesions? Yes, right, versus just degenerative, which is osteoarthritis. So again, this is arthritis, but it's not osteoarthritis, okay? What you need to know is women, primarily it's a 3-to-1 distribution, okay? Peak onset is late 40s, early 50s. I will tell you now, when you start seeing things like this on my slide decks, on our slide decks, mine and Colonel Sylvester's, we're giving you a pathway to, when you start reading vignettes, you think it might say something like a 45-year-old female with sudden onset bilateral wrist pain, and you're thinking to yourself, this might be rheumatoid arthritis, right? Because it says their hands, wrists, knees, and feet. That's kind of how it progresses, right? So you're going to see it more in what? The wrists and the hands, okay? Does that make sense? Yeah, I always try to give you guys some insight. Typically, symmetric. That's your first time, I think, well, at least today, right? Seeing something in gold, bold. Okay? So is osteoarthritis symmetric or asymmetric? Asymmetric. So therefore, rheumatoid arthritis is symmetric. Okay? So bilateral is a word you're going to look for in the vignettes as well. Okay? So it can meaning bilateral, meaning it's medial and lateral, or it's left and right. Okay? Does that make sense? Okay. And then, of course, it's a picture here showing, I have to use a different clicker, so bear with me. But the picture here showing a healthy joint. Osteoarthritis is more degenerative here, right? But in rheumatoid arthritis, you see that angry synovium? Okay, and you see that erosion there where the bone is meeting the bone now? Okay, and again on this side, right, you're seeing the more osteoarthritis is more degenerative there. Okay, and over here it looks angry, right? Red, inflamed, and the joint line is actually eroded, and you have bone meeting bone. Okay, that's more characteristic of rheumatoid arthritis. Okay, you guys good? All right, so those are some scope pictures. I will not give you scope pictures on your exam, but just, does this tissue here look happy or angry? It looks angry, right? So that's an example of what we'll see sometimes when we stick a very small camera into a joint and look at that synovium and say, ooh, that looks angry. You know, do rheumatologists sometimes send patients to us for biopsies? Yeah, because we're the surgery people, right? Okay? So just you're like, well, you say you don't see these people. We don't see them for management of their autoimmune disorder. We see them for very specific reasons. And we'll talk about those. Okay? Any questions about that so far? Okay, this picture here is not there on accident. You need to understand this picture. I told you guys I just took my research, no test compromise, but they asked me a question about that picture. So I can almost guarantee you from PANTS, you'll get a question about this picture, okay? But we'll get to that. So pain, morning stiffness, swelling, and systemic symptoms are common. You guys like words like common, right? Because you're like, oh, I need to know that. Okay? Yes, you need to know this. Okay? But just the big thing is the systemic part. Okay? It's systemic. Right? So joints of the hands and feet are usually affected first. Which joint there says? It says proximal joint involvement occurs later in the disease course. Right? And this, that point there where it says DIPs are spared, I would know that. Okay? Remember yesterday we talked about Bouchards and Hebertines, and those don't have any play in this. Those have anything to do with rheumatoid arthritis. It can be, right? Maybe like if you're involved in the joint, but those are Bouchards and Hebertines are more osteoarthritis, correct? So don't get those confused, okay? But just understand that DIP joints of the hands are spared. So you're going to get what? 20 to 50% of patients that have central and axial joint involvement. We'll talk a little bit more about that, especially as it relates to surgical intervention. Okay? And neck pain stiffness is common. possible myelopathy with atlantoaxial subluxation. Okay, so what does atlantoaxial subluxation mean? What is atlantoaxial? C1 to C2, right? So that's the rotation on the dens, correct? Don't worry, we're about to do that in lab tomorrow. You guys are like, I don't remember that. Okay. Tomorrow's lab is again talking about anatomy, relevant anatomy and radiographic imaging. Okay. But just understand that these patients, especially if it's disease has been on long enough, when they have atlantoaxial subluxation, when they go to surgery, do they have to be put on a table flat and their head extended, right? And to be intubated? Yes. So if they have atlantoaxial subluxation or instability, right, will they be potentially more of a challenging patient to deal with? Yes. So that's something that if you send a patient, for example, right, do you guys do PCM sometimes do pre-op clearances? Pre-operative evaluations? Yes, they do. Okay? So if a patient gets sent to you, you need to get a good history if they have rheumatoid arthritis. Because if they have a history of documented atlantoaxial subluxation, do you think the anesthesiologist that's going to be doing the intubation is going to want to know that information? Okay, so there's a clinical pearl for you guys. Untestable, just something to know. That's what that means. Okay, so, right. So this picture here. So, which way, right? When you're looking at this picture here, make sure I push the right button. Which way are the wrists going, and which way are the metacarpals going, the phalanges, right? So you see that medial deviation of the wrist, and that ulnar deviation distally there? That is pathognomonic for rheumatoid arthritis. That'll come up in another slide, okay? All right, this, I want you to memorize this. There will be at least 45 questions on a test relating to this chart, okay? No, I don't, okay? Again, I have to be fair to the game and make sure I'm complete to you guys. We're going to become PCMs and hopefully go on to do awesome things, right? But this is the criteria for rheumatoid arthritis, okay? So is there a bunch of labs thrown in there? Yes. Your clinical pearl for this slide is, if you are going to send a patient to a rheumatologist, do you think they're going to want you to do screening labs? Yes. So if you know this criteria, then you also know their referral guidelines, right? You guys know what referral guidelines are yet? Some of you do. But basically, you can't send them to me unless you do X, Y, Z first. Does that make sense? So get an X-ray for me, right? You try to send me a patient without an X-ray, what do you think I'm going to do? I'm going to tell you my X-ray vision is broken. I've been working on it for 30 years, but I'm still not there. Okay, so therefore, please get some screening X-rays. Okay, there you go. But in the case of rheumatology, they want these labs, right? Because then they might look at you and say, why do you think this is RA if all these labs don't make sense? Enough on that. So again, rheumatoid arthritis there, clinical symptoms, are they, and pay attention to this, extra-articular symptoms common in patients who are strongly seropositive. Okay, what does that mean? That means that not only do they have that bony erosions, but they have those systemic manifestations as well, right? So what things that we're talking about? There's a list, okay? I will allow you to read those at your own pace. Okay, but there's a bunch of stuff there that ortho doesn't treat, correct? Okay, pleural pericarditis. I have no business operating or working in the kill box. Okay, so if they have pleural pericarditis, they're going to see a cardiologist or a pulmonologist, some combination of that. Okay, so adverse outcomes of disease. If it goes on long enough, they have bony erosions, right? They can have joint contractures. Okay, does everybody understand what a contracture is? Okay, that is where parts of a joint are systemically eroded, and therefore there's lack of motion there. They are stuck in that position that was described in that radiographic image, and therefore if they are stuck in that position for long enough and the components of that joint are degraded, do you think they're going to be able to articulate and move like normal? No. So once you've been in that position for long enough, then it starts to stiffen. That's when it becomes a contracture. Make sense? So they're unable to articulate there anymore. They're unable to do the range of motion there. Okay? Pain, yes, right? and this is the first time I'll say this for this cohort, but ortho, we care about pain, but that's not our focus, okay? Pain is something you'll learn to treat with at your own, you have your repertoire, if you will, of different conditions, but pain is something you shouldn't ignore, okay? Loss of function, ambulation, that is important, right? Remember we talked yesterday about work, play, and sleep? If those things are affected, will patients come see you and ask for you to help them? Yes. So you're going to ask them questions like, hey, what is your activities of daily life like, right? Are you having issues doing certain activities, right? You're going to document that, okay? So physical exam, pain and swelling of the affected joints. They can have diminished range of motion and pain elicited by palpation, okay? You remember we talked about the synovium is that lining of the interarticular aspect of a joint, okay? But they can have a bogginess there, right? You saw that picture where it was warm, it looked like it was red, angry, right? So if they have that synovial hypertrophy that we mentioned earlier, which is that excess synovium, they can have a boggy joint, okay? What does the term boggy mean? Just throw it out. Somebody throw it out there. Sponge. Like spongy, kind of squishy. Somebody said like a squishy ball last semester. I don't disagree with that. Okay? And that's different than osteoarthritis because it's not an effusion necessarily, right? This is actually inflammation and erosion of the joint that has now caused excessive synovium, otherwise known as hypertrophy of the synovium, and now it's like a squishy bag of worms almost. That's the way we describe it in orthopedics, bag of worms. It feels kind of like something, you can feel things kind of squishing around there. Make sense? Okay? And synovitis. So synovitis, anytime you see the itis, right, that's just inflammation, correct? So you can say, well, there's inflammation of the synovium. Well, duh. That's kind of what we got us here. Okay? Good to go? Okay, can it be kind of warm at times? Yeah, because it's an ongoing process, correct? But not to be confused with warm to the point where you're concerned about infection. We'll get into that later. So under deformity there, what does it say? Wrist radial deviation and what? Finger ulnar deviation. You need to know this, okay? If you don't get a question on pants that relates to this, let me know, because I can almost guarantee you'll see something that relates to this. It may not necessarily be what you think, right? Maybe something where it gives you this in the history, it gives it to you. But now it wants you to make the appropriate treatment plan, or it wants you to select the appropriate labs you will order. Make sense? But this will come up in some way, shape, or form. And that the image that I showed you earlier, right, is that showing wrist radial deviation and finger ulnar deviation? Yes. Okay. Do patients that have early RA have this? No. This is a thing that you see more later on in the disease process. Okay. But without fail, this is present at some point if it involves the wrist and the fingers, which is very common, correct? Yes? Yes. The answer is always yes, guys. Okay. So you guys see that's another picture there? That's more of a physical exam picture, right? Physical exam picture, okay? That's what you'll see. Now you're like, I've seen people like that in the grocery store. I wonder if they had RA. They probably did. Okay? Right? Good to go? Any questions about that? Okay? There are other deformities you'll see. Lateral drift of the toes, plantar subluxation of the metatarsal heads. Right? So it's just basically, again, those joints, depending on what body parts are involved, erode, and therefore they're not normal in their articulation, so you can have subluxation, deformity, and or contractures. Eventually they'll have some level of contractures, right? Subcutaneous RA nodules at the elbows and ears. I think that's a decent picture, hopefully you guys agree, right there, of what those nodules look like, okay? Elbows and ears, okay? I've never seen them on the ears, so I gave you a picture of the ones on the elbows, okay? But that's what you'll see. Are those painful? Not necessarily, okay? And patients may say, oh, it's just unsightly, right? But that is pathognomonic for rheumatoid arthritis. Everybody understands what I mean by pathognomonic, right? It means it's a pointing, it's a finger pointing saying I'm RA, I'm RA, I'm RA, or I'm whatever condition, right? So as it says there in the subtext on the picture, they're usually non-tender. Okay? Down there it says non-tender. You guys can see that? Okay? So again, when you get a pants question, it gives you this setup, shoot the shot, make 2 points. Okay? Good to go? Okay. Any questions so far? Imaging-wise, are you going to get radiographs of the involved joints? Yes. When it comes to RA, and again, I kind of already alluded to this, and especially if they're going to have surgery, at some point you're going to get cervical spine x-rays, right? Because you want to know early if they have a axial subluxation. Okay? Does that make sense? But at a minimum for now, to begin with, you're going to get radiographs of the affected joints. Okay? Are you going to get bilateral radiographs? Yes. Because I told you they're symmetric, correct? Okay? Just because they don't have symptomology right away doesn't mean that they don't have early signs. Well, what are those signs, guys? They're on the screen. Okay? Osteopenia. Okay? Right? Not osteoporosis, osteopenia. Bony erosions. Erosions, again, go with RA, correct? Symmetric, and they can have malalignment. So what does malalignment mean? It means they're not aligned like they should be. Just that simple. That could be, again, due to those erosions, okay? Good to go? Okay. Lateral flexion extension views of the C-spine. Again, that'll show the C1, C2 instability due to erosion of the odontoid ligaments. You guys remember the odontoid ligaments, correct? You can describe them in detail. You can tell me what length they are average on an adult female at the age 32, correct? Sure. Okay. I'm not going to ask you this question. Set you up. But the point is, C1, C2 instability is important. If I'm going to take someone to surgery for their knee complaint, right, say they have a meniscal tear, and they happen to have RA, as an orthopedic surgery PA, am I going to get cervical spine x-rays? Yes, of course I am, because I know the anesthesiologist can walk them. So as a PCM, you will as well, okay? Does that make sense? Okay, labs. I am not the lab guy, but I certainly know a lot about labs because I've worked trauma and a bunch of other areas as well. But anyways, the important thing about labs for RAs to understand what they mean, okay? You guys have been through courses already, and like pathology, for example, where you talk about specificity and sensitivity, right? Every semester I ask the question, what's the difference between specificity and sensitivity? Some people got it, some people tell me they got it, and then later on they're like, I don't got it, right? But at some point you have to understand the difference between specificity and sensitivity, because if you don't, then you don't understand why you're ordering labs and what they mean at times. Does that make sense? Okay, so however you remember them, I remember specificity as they don't have it, and I remember sensitivity as they definitely have it, or at least there's a high likelihood they have it. That's how I remember it. Okay? I don't know how you remember it, because if you read a different textbook, for example, internal medicine literature, they describe it all tricky and wizardry and all this stuff, and I'm just a little nerdy about it. I just remember specificity, they do not have it, right? In specificity, usually you're going to do a screening lab, right? Is rheumatoid factor a screening lab? Yes, for rheumatoid arthritis. Remember I showed you that list I told you to memorize and you have 45 questions about it? It's on it, okay? So therefore, if they are positive for that, then I get other labs to say that they do absolutely have it now, since they showed evidence that they don't have it. I'm going to stop talking, because I'll probably confuse people that thought they already knew it, but that's how that works. Okay, read, watch the video again if you need to, approach me, or ask a question right now, because I'm telling you, you've got to understand that concept, okay? Right, okay. Inflammatory markers, ESR, CRP, erythrocyte sedimentation rate, and C-reactive protein. Is there a CRP for cardiac as well? There is. Don't order that one. When you go to your facilities, figure out which one is which. One is for the heart, and one is not. Order the one that is not, because you'll be wasting time. Labs take forever to freaking run them anyways, so don't order the wrong one and get more fuel for the fire, okay? So, but ESR and CRP are inflammatory markers. Are they specific or sensitive for any one condition? No. Okay, so that's a concept, an idea that you guys need to understand now, is you'll see labs come up repeatedly, right? And I'm gonna keep telling you, yes, you order inflammatory markers, but they don't necessarily paint the full picture and nail you down to a specific diagnosis, okay? But RF is positive in what percentage of patients that have, rheumatoid factor, RF. Is positive for what percentage of patients that have RA? You need to know this number, okay? It's in gold, okay? 75 to 99. Is it 100%? No. Again, it's a screening lab, right? But not specific. So remember I told you that RF is a specificity test, correct? Does anyone remember what I said 120 seconds ago? No? Yes, because that's what I said, basically, okay? So if you understand that concept, you understand why it's not specific. Okay, so if you don't understand, keep asking me questions, and I keep trying to unconfuse you, right? Or I'll just confuse myself. But anti-CCP, you guys are familiar with that lab yet? Okay, citrullinated, citric, all that stuff, nothing? Okay, so anti-CCP, you don't know what that is, you guys have other sources to look at that as well. But the important thing to know for this course is that it's as sensitive than RA and more specific. I should say RF. Okay, got a little excited there. But more specific. So that's not a test for specificity, but for sensitivity, correct? Okay, so do you think we use those tests together? We do, okay? So both RF and anti-TCP, right? So let's say they're both positive, correct? That's what it's getting at there. It's 55% sensitive and 97% specific. Okay? So it tells us that that patient more than likely has rheumatoid arthritis. Okay? Is it 100%? No, but the chances are high, right? So this is how you use those labs. So RF and anti-CCP are both positive. You can almost, right, with a certain degree of certainty, diagnose that patient with rheumatoid arthritis. You still have to use that criteria, that chart that I made you memorize. Right, you guys already memorized it, right? Yes. So that, yes, of course, right? Are there other labs you ordered? Yes, of course. This is not that course. This is what I'm going to ask. Sir.
Sir, so if you have somebody with have pneumotic findings with physical exam, do you still have to order these labs to confirm it?
100%. Yeah. Nobody saw that. 100%, right? Because that's the diagnostic criteria. That gets to a good point, Collins. Why do these diagnostic criteria exist, guys? Have you guys looked in your studies so far and you've seen diagnostic criteria for other conditions? You guys know about the Wells criteria yet? You will. You're in cardio. You'll know about it soon. Okay? So those criteria are established because that is across the board as far as the science of it, right? The meta-analysis, the studies, patient experiences, provider experiences, all that's taken into account and made by the bodies that represent those specialties to say, hey, this is how you should be treating these patients. This is how you should be evaluating these patients. Does that make sense? So those are important to know. So if you see something like diagnostic criteria, right, you need to make sure you're like, that's something that's important. By the way, it's the age of technology, right? Do you guys think there's apps out there that have all these calculators with all these criteria in them? Yes. And do you think that myself, as an orthopedic surgeon PA, when I'm rounding on patients and inpatient, because we're doing total joints, right? Those are old sick patients, right? That I have to look up those calculators sometimes? Yes. So get used to that, okay? Find those resources, I keep telling you guys. Find the ability to find those resources. That way, if you're looking things up in clinic, you're not trying to, like, remember all that, right? Einstein said you should never memorize something that's easily referenceable. Now, he's a smart guy, he can say that. But I'm just telling you, you'll learn to use your resources, okay? Sorry, about no tangent. Okay, platelet counts can typically be elevated in patients with an acute flare, but that says acute flare, right? Does that mean anything? You know they got RA. You know they got a flare. Do you think the white blood cells and the platelets are doing things to try to counteract the systemic attack that is occurring at those areas? Yes. So that's just kind of a, you may see that as well. when they're having an acute flare. Is that diagnostic, guys? No, kind of belongs in the same category as the inflammatory markers. So it's to sum up this slide, I apologize for the typo, I will correct that. But RF and anti-CCP, if those two exist together, it is RA until otherwise proven, as long as from a laboratory standpoint though, right? Does that make sense? You still have other diagnostic criteria. You just do labs and say slam dunk. No, you would get the x-rays too, correct? And so don't overlook one for the other, okay? Did I answer your question at some point?
Yes, sir.
Okay, good. All right, so treatment-wise, again, I'm not a pharmacist. I'm not a pharmacology guy. Yes, I do have a degree in pharmacotherapeutics because I hate myself. But I will tell you that the only thing that I want you to know is these two categories, okay? That's all I'm getting at. Am I going to ask you dosages, routes, frequency of administration, things like that? This is where the answer is no. Okay, I will not ask you this, but I will potentially ask you a question that leads to the class. Because does rheumatoid arthritis specifically, does it have its own class? Yes, DMARDs, okay, right? Non-biological, synthetic. Okay, disease-modifying anti-rheumatic drug. That's what it stands for. So it has its own class, right? So what do you think the first line is to treat the autoimmune systemic process? DMARDs, right? So, and then if you can't, see how it's in yellow, right? So it's kind of important, right? But if you can't, you're not getting adequate treatment, then you can go to biologics. You guys, especially if you stay up late, nobody stays up late in this class, right? Or you stay up late, you look on TV and you see those ads for all those autoimmune disease, right? It tells you if you've had a fungal infection, if you've had a, all this stuff, you shouldn't be taking this. It scares you, you're like, I never want to be taking this because it sounds like this is worse than the disease, right? Those are the drugs we're talking about there. I don't even list them on this slide because I'm not going to ask you about them, okay? Does that make sense? Now, I can if you want. I can always add another question to the test. But you get that in pharmacology, okay? Good to go? Fair enough? Okay. Adjuncts, why are they called adjuncts? Because they are on top of trying to treat the underlying disease process, correct? Okay, so you're always going to try to treat the underlying disease process. Pause for effect. That may come up soon, okay? But if the patient comes in and says, I'm taking all these pills you tell me to take, I've seen the commercials. Sir?
I just wanted to check, so the second line for the TNF alpha inhibitor, that is for refractory.
It's more complicated than that. That's why we don't get into it. Right. So his question was, is that first line, second line kind of stuff? I will tell you that for most patients that DMARDs is kind of the go-to, but then there's a lot of TNF alpha inhibitors as well that are used concomitantly. Okay, that is a very complicated subject and not in the purview of orthopedics. Make sense? I'd be happy to go through it in detail with you if you'd like. My office hours are whenever I'm there. But I won't want to waste the class time because I'm not going to test you on it. Okay? Do I think it's important? I do. Okay? But again, I'm not the pharmacology guy. Okay? Sometimes I am. All right, so again, adjuncts, you're going to use them in combination for more so the secondary symptoms. Do you think if someone has inflammation and destructive erosive processes and lesions, that they're going to have pain? Yes, right? But these are things you're going to use. These are things in your toolbox you're going to try to use as well. Acetaminophen, that's Tylenol, right? Tramadol, right? So I was actually working in orthopedics when tramadol came out, right? Some of you guys are more seasoned. I don't say older. Seasoned, remember, we used to give it to everybody. Non-addicting, non-habit forming. Yeah, that's not true, right? So tramadol, be careful with that because that kind of goes with opioids, correct? Lidocaine, okay? But when they're talking about lidocaine there, that's injectable versus those patches and pads and stuff you guys are going to talk about in pharmacology, okay? Anti-inflammatories, the same old stuff, right? So NSAIDs, that what we discussed yesterday, and steroids, oral, IV, or intra-articular. Intra-articular meaning you do an instant injection, okay? So if you get a question, say in the near future, right? and it asks you, how do you treat the underlying process? And you choose an intra-articular steroid injection. Are you right or are you wrong? You are wrong, right? Because the question is asking you how you treat the underlying process, right? Because that's what's important to know. How many times do I have patients refer to me to do these injections in my career? Maybe twice. They try, but I tell them, I say, well, that sounds like you need to see a rheumatologist. Does that make sense? And it's not because I can't do the injections, but those patients need somebody to treat their underlying disease process, not just me putting a Band-Aid on it. That's nothing to do with my skill set. It has to do with me recognizing they need their autoimmune process addressed. Good to go? Okay. Have I beat that to death yet? Okay. So operative, again, not very very extensive experience on my part, but what does it say there? Synovectomy, tenosynovectomy. That's where we do ectomies. That's where we start slicing and dicing. And say they have a contracture and something's bowed down, or bowed volarly, bowed radially, and it's causing a significant impairment. Can we slice and dice and loosen things up and open them up and get them to move again? Yes, that's what it is. It may prevent tendon rupture and progression to a joint deformity. And I will go a step further to say if they already have one, that we can help relieve some of that as well. Okay, does that make sense? That's as far as we're going to go with that. Okay, I'm not going to get into the surgery stuff. I took all that out of my slide decks. End-stage arthritis, this is where we see patients. Again, not very commonly, but if they have end-stage arthritis, what are your options? Arthroplasty versus arthrodesis, like we discussed yesterday. Who does arthroplasty? This guy, right? Love it, right? So that's the thing that we will see patients refer to us for, because we're the ones who should be doing those surgeries, correct? Okay. All right, good. So again, in following the text, the style of your textbook, what are some of the adverse outcomes of what? Treatment. Always those NSAIDs risks we talked about, right? Injection risks always stay in place. That includes infection, right? Do you think that people with autoimmune disease processes are more prone to infection? Yes. What does autoimmune mean? You, not you, sir. I'll look at the wall. You hate you. Your body's trying to destroy you, right? And is infection will destroy you? Yes, it will, right? So again, be careful when you're considering doing these injections. Maybe in the RA population, even if you know how to do certain injections, you send those to a rheumatologist. I'm just saying. I'm not trying to get on your skill set, right? You guys are going to be awesome, I get it. But just be careful with that, okay? Post-op complications, again, you hate you, right? So do you think that they're more apt to not heal surgical incisions and from surgical procedures? Yes. So if you see a patient with RA who is post a arthroplasty, so a joint replacement, and now they're having fevers of unknown origin, and they're having significant pain, redness, swelling, right? Does infection need to be in your differential? Absolutely 100%, okay? I want to stop there and take a break, right? I spent a lot of time on RA. It is important, guys, okay? All right, let's come back and top the hour.
I saw that.
Maybe you should do one.
Like, I'm
That is too much work. Just use it as a warmer, yeah.
So there's a little like because they need to rule out. Because in a sense, if you're negative, you're negative, but you're positive, you're like 5 trucks in the front yard.
better. And I'm using my Wi-Fi right now. Yesterday I kept switching, and then like it would delete everything I did. So I had to go home and do it again. Alright. Waste my time again. I thought you
Hours.
Let's do it.
I don't need the my fucking bloodline. Dude, I don't need this in my bloodline.
Not even like the one night.
We'll put instead of like plastic bags, it's just on my hands.
Like,
She likes putting your stickers in the Crystal. It's for you. You're gonna do it. Yeah. Do it. Really? So excited.
Yes, mine too.
Literally, I reread Ortho is yeah, I get
next
I tried to study yesterday, I wasn't ready to time. If I start, I was like, I need to warm up. Yeah. It's like I already did a full semester.
yeah, exactly. Just doing it for the rest of the
At some point, just because of all that,
I'm ready to do my fucking mind. I feel have a pen search on. Yeah, that's how I
Sorry. What's that? I was like, so should I go? I was like, nurse. She's like,
Like I'm on like it's like really nice coffee maker. Dude,
yeah, it was
no, it's automatic. It's literally like it grounds the coffee beans. You put the coffee beans, you put all the coffee grounds in the cube, and it just gives you like yeah, espresso. Yeah, I make it with Americano because I don't like these little cups. And I make Americanos, dude. Yeah. They did a little research. It's like, she wanted to know about it. I can draw. What was that?
Yeah, but our problem is just the other R wave. That as long as that like notch between the R. Oh well, but like
That's septal.
Oh, no. It's there in bundle
So
range.
septal. So you got left and you got your right bundle branch. So your left bundle branch depolarizes your right bundle branch. Our time is your left bundle branch. Then depolarizes your right bundle branch. There's an RS. That is your left bundle branch. Normally those things are attaching together. It's just one.
Yeah, it's hard. Yeah, it's called bundle range walk. So that specific double R's is because the right bundle range walk. And if the QRS complex is inverted, it's going to be a left bundle range walk.
So your left bundle branch is sensing the right bundle branch. So that's it's normal. It's just blah blah. You get
The RR. Well, as long as the R, if these two R waves and it doesn't go below the isoelectric line, it's just right bundle range. Because when you go, the QRS complex, if it's dark,
Right now it'll be a right track.
yeah, if the QRS complex is so right bundle range walk, and the QRS complex is inverted, it's a left bundle range.
But that's
Yeah. Then she's gonna go for that. That's the R.
you see like the R.
What are you talking about?
This semester, how I gave like the first, like where was the first
Yeah, these are all super big spiders. Even bigger than these ones.
Did he offer any words of wisdom?
You guys ready to get going? Always ready. Right. Got some fist bumping going on, some team building back here. Love it. So, the air in here is dry, right? We're drinking so much water, and last semester we were freezing our butts off in here. So, you got a deep blouse. I don't care what gear you wear, your facilitator can give you a better idea about that. You know, but on any lab day, before I forget to mention it, if you have a lab that vape, regardless of whether we're going to be doing downstairs or up here, you're more than welcome to wear PT gear. Okay? Good to go? Alright. As I clear my throat. Alright, so that was seropositive spondyloarthropathies, right? Alright, and you look at yourself and you say, well, I know what seropositive means, and Major Davlos is a liar. Because he just told me they could be RF negative, so therefore wouldn't it make it a seronegative spondyloarthropathy? Don't go that deep. Deloach. Don't go that deep, okay? Those things are classified that way for a reason, because again, upwards of 99% of people are seropositive, correct? And a student astutely asked me and make a comment, say, well, what if they are RF negative? Do they still have RA? Yes, right? Early in the disease, they may actually be seronegative, okay? But later on in the disease process, is it the potential for them to convert to seropositive? Yes. Okay, so that's where I stop, because then I become a rheumatologist, and you guys know I'm not one, right? I'm outside my depth. But I'm just telling you that these things are lumped together, and how do you think I'm going to test you on it? I'm going to test you on the way I present it. Okay? Good to go? So, therefore, seronegative spondyloarthropathies, right? So those are going to be RF negative, right? Okay. So, it says it right there, because they are negative for RF. Okay? Axial skeletal is commonly involved, and patients often report back pain. Okay? Can patients have back pain and not have a seronegative spondyloarthropathy? Absolutely, but this has just become part of your differential if the patient shows signs of autoimmune disease, correct? The answer is yes. So I have changed this slide deck, okay? Obviously, you can see my change. I added this for you, okay? This is how I remember things when I got to take boards. The pair, okay? Because there's a couple of different kinds that are more common. Are there more than this? Yes, but these are the more common ones, okay? The P stands for psoriatic arthritis, the E for enteropathic. What does entero mean? Related to the gut, correct? Okay, so there'll be some involvement there, okay? And ankylosing spondylitis, and then there's reactive arthritis, okay? It used to be that we called reactive arthritis Reiter syndrome, kind of gone away from that, then we come back to it, but they're the same thing. Okay, what is that reactive arthritis? What is that mnemonic that you guys know? Can't bend the knee. Can't see, can't pee, can't climb a tree. No Game of Thrones references, please. Yeah, so that's what it is. Can't see, can't pee, can't climb a tree. Okay? So again, when it comes to reactive arthritis, otherwise known as Reiter syndrome, that was a joke, by the way. I like that. Do you think you're going to have to treat something else besides their arthritis type symptoms? Yes. So just understand that. Okay, but pairs, that the way I want you guys to remember it. Okay? If you want. If you don't want to use that, great. Just memorize them, move on. Okay? But those are the most common ones and the ones we discussed in this course. So, enteropathic arthritis, just to get back to that one real quick. That is arthritis with IBD, irritable bowel disease, right? So again, it involves the gut. So don't get confused in that terminology. It's just a nice way of saying what's enteropathic and fits the pair nicely. So that's not going to remember. Okay. Same thing. Okay. I want to trip you up from other courses. So I told you it affects the axial skeleton, correct? Okay. So center line, if you will. Okay. This is the spine block, right? So axial skeleton. Okay. So can they have sacroiliitis and kyphosis? Yes. Right? I always think when I look at this picture that this patient looks like a frog for some reason. I don't know. All right? But see how it's an axial skeleton, it's center line, more so. Yes, the shoulders are glowing too. Right? But more so commonly the axial skeleton. Right? So, and kyphosis, do you guys know what kyphosis is? That's the hump, the slump, if you will. Okay, and we'll get more into that when we talk about it. I have some supplemental slides that I came up with just to clarify that a little bit. Okay, so we'll get into that. But now, when you're talking about deciding what the populations are that this presents in, you talk about the second to third decade of life, and 3 times more common in men. Correct? Okay. Again, this is ankylosing spondylitis, right? So this is a specific lab for ankylosing spondylitis. So 92% of patients are positive for which lab? HLA-B27, okay? If you get that wrong on pants, I don't want you to get it wrong on pants, all right? It kind of goes with that, okay? So if they ask you, if they give you a scenario where it's a 33-year-old male with lower back pain who's positive for HLA-B27 and also positive for all kinds of random craziness, but that's the one you pull out, right? That's the one you pull out. What's the answer? Ankylosing spondylitis. You look at your answer choices, make sure that it's there, right? Make sure you didn't misread the question. You select that, and you move on with your life. You got 2 minutes-ish per question, right? You gotta be efficient, right? So start putting things in the park. Okay. Right. Systemic manifestations, I don't really get into these, but again, they can have them. Uveitis, iritis, aortitis, cardiac conduction abnormalities in 33% of patients. You notice how that's not highlighted, right? The other thing I want you guys to understand is from an orthopedic standpoint, it's axial skeletal, and that they can have other systemic manifestations, correct? Is HLA-B27 an indication that their body hates them in some way? Yes. Okay, so again, they can have systemic manifestations. Okay, good to go? Did you guys already talk about AS in other courses? A little bit? Probably talk more about the cardiac stuff, right? Maybe. I won't. Okay. You're welcome. All right. So now we're moving on to our, I don't like to use the term RA, so I call it riders, if I call it something else. But reactive arthritis, can't see, can't pee, can't climb a tree. So that tells you what systems are involved there and what their presenting symptomology can be. And it also tells you what kind of studies you should look at, correct? Okay. 63 to 93% are HLA-B27 positive. Great. But it's precipitated by GI infection. Okay, so do you think you have to treat that condition as well? 100%. So you gotta chase it down that rabbit hole. Okay. So it can cause arthritis, urethritis, conjunctivitis, and mucocutaneous lesions. Those mucocutaneous lesions don't really fall into that can't see, can't pay, can't climb a tree. So just add that to your repertoire. Okay. STIs, sorry, not soft tissue infection. Right? I hate STI because it's used for so many things. Right? You'll see that abbreviation used in medicine for so many things. But this is a sexually transmitted infection. Right? Chlamydia, gonorrhea, etc. Okay? So you think you have to treat them for that? Yes. So again, you have a history, right? So this tells you the kind of history you're going to have to take. You're like, well, wait a minute. I'm seeing a patient for a musculoskeletal complaint, and now I got to do a full comprehensive history on them? Yes, it's important. I told you that yesterday, right? Because you may miss this if you don't, right? Which one's in yellow? Gold. Chlamydia trachomatis, that's the most common, right? And you can have a list of them, right? Because it's not just GU, but it can be GI as well, right? You got to see some GI bugs on there, right? Okay, Shigella, right? Things like that. Yersinia. Okay. All right. So you guys hopefully appreciate this picture again. Can't see, can't pee, can't climb a tree. Okay. All right. Any questions about this one? Okay. So if you get a question on pants and the answer is how do you treat this? All right. And you look on there and it's a choice of an antibiotic. Is that what they're asking you? Yes, they're asking you how to treat that infection. So the second order, or third order, depending on how you look at it or how it's presented, is do you know the antibiotic? Does that make sense? Okay. I won't test you on that. I'm just preparing you mentally. Because you'll look on there and say, oh, this is writers. In Ortho, they said we do this. But wait, we're more of an infectious disease specialist right now for the purposes of this question. All right? How do you treat this? Make sense? Will their eye issues and their joint issues and all that get better if you treat the underlying cause? Yes, that's what they're getting at. Okay. Psoriatic arthritis, PSA. I hate that abbreviation too, because it's capital P, little s, capital A. That's used for other tests too, right? PSA, prostate-specific antigen. So, but psoriatic arthritis is abbreviated as such. 18 to 42% of patients with psoriasis in North America and Europe. Male is actually equal to female, And what's the average age of onset? Late 30s. You see this very, very young, relatively speaking, right? What do you guys consider midlife now? Right? Is anybody here in midlife crisis? Because people are living longer now, right? So 30, 40? Thank you. I appreciate you. Yes. But just on the onset, late 30s. And I will tell you this is a side note, and maybe somebody here is doing their CI project on psoriatic arthritis. But we're seeing a lot more often, right? And what is causing it? Do people know? No, they don't. We're just seeing it more often. Okay. So 5 patterns of psoriatic arthritis. I abbreviated as PA there, or it was abbreviated as PA, because again, PSA is just too confusing, right? I won't abbreviate things like that on your test. If it's psoriatic arthritis, I will write it out, okay? So don't worry about the mix there, okay? I guess it doesn't also stand for physician associate assistant. Sure, like again, we have to be on the same page. But DIP joint arthritis, how is that different? Does RA affect the DIP joints? Okay, we just found a common point. You're studying, you're laying those reading sheets over on top of each other, looking for things how they're different. Here's an example, okay? So DIP joint arthritis, asymmetric oligoarthritis, okay? So again, this is different, okay? But symmetric polyarthritis. What's the difference between oligoarthritis and polyarthritis? Few versus many, but there's a number associated with that. Okay, 5. Somebody said 5. That's not incorrect. Okay, remember how those criteria that I showed you earlier of that chart, and it says how many joints are involved and whether it's bilateral, essentially. All right, so this is how you differentiate that. Okay, so don't let that throw you off. I won't get that tricky on the questions, but you need to know this kind of stuff. Okay, what's the next one? Arthritis mutilans. This is pretty gnarly looking, right? When you see this, you'll be like, oh, okay, this dude looks like he has carrots for fingers. Like knobbly, wobbly carrots, right? So that is a more aggressive variant, if you will, okay? Or an indication of long-standing disease process, okay? Sacroiliitis, excuse me. So everybody knows what the sacrum and the ilium is, correct? All right, if you don't, we're going to go through some stuff tomorrow in lab. Okay, tomorrow we'll try to have some fun, okay? My kind of fun, and for the purposes of my kind of fun. But sacroiliitis, so when they describe their back pain, where do you think they're going to describe it more? Is it going to be in their neck, or is it going to be down right about here? Down right about here. That kind of hurt when I pushed it. Yeah, but DIP, joint involvement, absence of RA nodules differentiates symmetric polyarthritis from rheumatoid arthritis. Take a deep breath. I won't ask you that. Okay? But if you understand that concept, when you're doing a search on your literature, and you have a patient in front of you, and you know that chart, right? When I told you about your assessing which joints are involved, whether they're bilateral, symmetric, whether there's 5 or more joints involved. If this concept is in place, and you're trying to differentiate between what? RA and psoriatic arthritis, this will help you get there. Does that make sense? Again, that's why these diagnostic criteria exist. Okay? Do they have skin involvement? Yes. We know that psoriasis is this dermatology condition. You have not had dermatology yet. You will not have it until next semester. Okay? We just understand that dermatological manifestations may coexist with this. And by the way, they do. Okay? Good to go? This is ortho, right? So everything you see there is joints, bones, spine, things like that. Okay? Any questions about psoriatic arthritis? Okay? So we understand that the dermatological condition for psoriatic arthritis is psoriasis, correct? That's not too much to assume, right? And psoriasis is those plaques, right? Those white scaly plaques that you see people on flexor surfaces, right? More commonly. You guys have seen people in the grocery store, like the PX, right? And you're like, oh, that's psoriasis. Okay. That's all I'm going to say on that. Okay? Arthritis associated with inflammatory bowel disease, otherwise known as enteropathic arthritis. It can occur with people with ulcerative colitis, and Crohn's disease, right? You guys remember UC versus Crohn's? Have you guys gotten into that yet? I think you have, right? In pathology? Yeah, okay. Right, so you understand, and please, you have to understand that I'm a field guy, right? So sometimes I use some choice words. But I remember that when it comes to UC, is that from the mouth to the anus? Or is that normally further down below? Further down below. So Crohn's disease can occur anywhere between one hole to the other hole, right? So not to get crude, but that's how I remember it for boards, okay? But incidence is 10 to 20% more common in patients with Crohn's disease. So then might they have significant manifestations in if it's GI involved? Yes. The reason I tell you that is because if you understand what Crohn's disease is, you understand that, yeah, you can start some treatment, but you need to get them to a specialist, right? Because you don't want to be managing that. Okay? And they have bleeding that leads to anemia, that leads to perforations, that leads to death. Absolutely 100%. So you got to get someone else involved. Phone a friend. Okay? Good to go? Okay. That's all I'm going to say. 50 to 70% are HLA-B27 positive. So HLA-B27 positive keeps coming up, right? So again, when you're doing reading sheets, if you choose to, I'm not making a joke, but if you choose to, then you understand that that is a common factor for a bunch of them, although a higher percentage in some of them. But if you have axial skeletal involvement in a male that's 33 years old, no skin manifestations, no bowel disease, or sexually transmitted infection, your diagnosis is still ankylosing spondylitis. See how you just work through that? Some of you are saying thank you, some of you are saying whatever. But you'll get to it, I promise. So here's a kind of a summary, if you will. I'm not sure how helpful this is. I think what I just said was more helpful. But understanding that when you're talking about these disease processes, they're all seronegative spondyloarthropathies, correct? And you see how some things are in yellow? Can't see, can't pee, can't climb a tree. Go to the answer choices on pants, look for it, and choose the right answer. Same thing with DIP joint involvement when it comes to RF positive, right? Then you're thinking what? Psoriatic arthritis. Right? I just said RF positive. Right? So it should be negative. Feel free to correct me. Okay? RF negative. And it involves a DIP joint. If you choose RA, are you wrong? Yes, for the purposes of diagnostic criteria. When you guys get out in practice, again, I'm not ignorant to the fact that you guys are going to get out there and be like, that guy's a liar. Okay? I see patients that present like this. That's great, but this is what the textbooks teach, right? And therefore we have to be fair and hold you accountable to this. You will see that things change in medicine. That's why if you guys learn an algorithmic manner, then sometimes that'll fail you in the future. So I tell you that try to take things in with the understanding that things can change and things do change. Make sense? Okay. That's why there's specialties, guys. Okay. Good to go. Any questions about this slide? Okay. Again, getting with a physical exam now. Now we're just classifying the conditions, right? Get into the physical exam findings. With ankylosing spondylitis, do you think if they have like kyphosis and that they have that central involvement of the axial skeleton, that they're going to have some kind of abnormalities on physical exam? Yes. Okay, so on physical exam for ankylosing spondylitis, they may have limited range of motion. It's very common. Okay, you guys know what a Faber test is yet? You do, right? And so I will teach you guys this semester that the Faber test, what you guys probably know more so, is that it's used for sacrum, right? But do we also use it for hip pain? We do, right? So Faber test can be positive, so it's not one of those things where you just say Faber test positive. What is it positive for? Because that test is used for multiple conditions, right? Make sense? But if you perform a Faber's test, right, flexion abduction, abduction, external rotation, and the patient points to their sacrum, right, to their sacroiliac junction, if you will, Is that positive potentially for AS, ankylosing spondylitis? Yes, that's pertinent. But if you do a Faber test and you say it's positive, but they point to their anterior hip and say it's deep inside the hip joint, does that belong with AS? No. We'll get into that next block. But just understand that with that test, okay, guys? Enthesitis, inflammation of specific points where tendons or ligaments attach to the bones. Okay? That's what it's showing here in this picture. You see it right there where it says enthesitis? Right, that's that junction where the attachment is. Okay? That's a junction where the attachment is. Okay? So that's how this is different. That's where they have that pain. Make sense? Any questions about that? And swelling, inflammation, and they can have nail abnormalities as well. Okay? Is nail abnormalities a dermatological manifestation? It is. Okay, so don't let that trip you up. Okay? It won't have the plaques though. That's psoriatic arthritis. Okay? Imaging, you're going to get x-rays of the affected joints, right? The affected body parts, excuse me. In psoriatic arthritis, you need to know these classic findings on radiographs. Okay? So in psoriatic arthritis, you have reabsorption, not erosion. That's a different word, right? Reabsorption of the phalanges, bone reaction in the DIP joint. There we go again with the DIP, which distinguishes it from RA, correct? In ankylosing spondylitis, yes, you do have narrowing of the SI joint. You can have that in old dudes like me anyways, right? I'd say it goes undiagnosed. Just because somebody started having disease symptom at 33, does that mean they were diagnosed? What's the percentage of people that don't seek medical care in the United States? Anybody know? High, very high. You're not wrong. There's a number attached to it. Okay? But if you get an x-ray, you see bamboo spine. Oof, that goes with ankylosing spondylitis. That lives there. That can only be ankylosing spondylitis for the purposes of the exam test. Okay? Ask a question. Low-hanging fruit, guys. Also called poker spine. Never heard anybody call it that, but sure. So basically, bamboo spine, you'll have a picture of it. If it's not clear, I'll give you more pictures of it. Okay, but there's fusion at the end plates. We'll get into that. Yeah, but the disc spaces are preserved. Okay, the disc spaces are preserved. Okay. Laboratory, again, I'm not going to beat that down. That's what you're going to do. Are you going to get a UA for reactive arthritis, Reiter syndrome? Or just Reiters? All right. Yes, you will. Yeah. Because if you don't, you're missing the bigger picture. Yeah. Any questions about those labs? Imaging again. Excuse me. Imaging again here. It shows you some pathognomonic, some like, hey, I am this condition type findings. Okay. In psoriatic arthritis, if you see the text in the vignette on pants that says pencil and cuff deformity, it is psoriatic arthritis. Forget the labs. It is psoriatic arthritis because it has to be that, okay, guys? If you see bamboo spine, right? So that on the right, it is ankylosing spondylitis. Save yourself time. On the test, you're like, it has to be that. Look for the answer choice. There it is. Click it. Move on. Okay? All right. So end plate fusion. So you see on the end plates there, right? So end plate, anterior here is one end plate. So it's on the end, the anterior end, and the posterior end here. All right? So anterior end, where the arrow is, and posterior end here, those are fused. But look, and you can see that the disc spaces are preserved. That is bamboo spine. Okay? Why do I tell you that? I've never seen it asked where they give you a radiograph and say, what is this? But it's certainly fair game. So if you see this finding, right, this is bamboo spine. Good to go? All right, you don't see what? You do not see erosions. You do not see degenerative changes. You do not see narrowing. You don't see loss. Does anybody see loss here? You don't see LOSS, right? You see end plate fusing, and you see preserved disc spaces. Good to go? And treatment-wise, when you're talking about seronegative spinal arthropathies, right, then you're talking about what kind of medications. A lot of times the word, or the medication methotrexate kind of gets thrown in there, okay? Endomethacin, okay? Effective in controlling symptoms in many patients. Specifically for ankylosing spondylitis, you can use the TNF alpha inhibitors. Okay, and that's to patients when their symptoms are not controlled just with an NSAID. So you gave endomethacin, didn't help. Now you go to the TNF alpha inhibitor, correct? That's what it's saying. Reactive arthritis, Reiter syndrome, you have to treat the underlying infection again. Psoriatic arthritis, here's where it gets a little confusing, right? Because DMARD stands for disease-modifying anti-rheumatic. But remember, psoriatic arthritis very common, can be very commonly mixed picture with RA, right? So therefore, do you think the disease process has some crossover at some cellular level? Right, it's thought that it does, therefore the treatment is similar, okay? But why does it say phototherapy for dermatological manifestations? Because without fail, if they have psoriatic plaques, right, phototherapy is the treatment for that. Make sense? Okay. Don't let that throw you off. Okay. Arthritis with the IBD, inflammatory bowel disease, treat the disease. Duh. If it's Crohn's disease, I can't get those patients out of my clinic fast enough. Right? Because they're just, do they come back? Yeah, they do. You know, and that's not to be insensitive. That's just to say that maybe they need a specialist to take care of it. Because if they are on active duty, you'll find people on active duty that have either of these, right? The only reason they're allowed to remain on active duty, and they might have to go to a med board every year, is because their symptoms are well controlled. And usually their symptoms are well controlled because they're undergoing treatment through a specialty. Make sense? Okay, so don't do them a disservice either. Make sense? All right. Unfortunately, I have to sit on med boards at a high level. So operative, all right. So if it's a joint, what do you think? The joint is gone, wasted, done for. We got to replace it, right? Okay. So therefore, arthroplasty more common. Okay. And then that's kind of it for that. Okay. Red flags for forward decisions, not all to orthopedics. I took out the underline and the exclamation point, and I want you guys to think I didn't care about these patients, right? But I don't manage these patients. So who does? Rheumatology, eyes, ophthalmology, skin, dermatology, and pulmonology, excuse me, if they have pulmonary manifestations. Okay, makes sense? If they have pericarditis, do you think they may have pulmonary manifestations as well? Yes, I'm not the guy to treat those. Okay. All right, any questions about that so far? Okay, we're on a good pace today. You guys doing okay? I'm going to keep pushing, okay? But I thought it was important to slow down a little bit at least so you guys kind of get a flavor of how I lecture, but also to understand that PANCE tests you commonly on common things. And for whatever reason, right, if you guys go to a review course, you'll hear this very often, they will test you on common things that don't commonly occur. Meaning that there's common subjects that are taught, but that you may never see in your career, right? They like the weird things, that's what I'm saying. So I try to pick out little things here and there where I'm like, yeah, maybe this isn't exactly what things are in the real world, but this is what they test you on. I'm not an NCCPA hater, please don't take it that way. It's just funny how some things I'm like, man, I've never seen this, right? Or I don't think of it in these terms. All right, moving on. Compartment syndrome. So we understand that we have compartments in our body, and in those compartments we have muscles, tendons, joints. We have what? We have nerves and blood vessels too, right? It depends on how you look at things, but there's major compartments. When we talk about compartment syndrome, we talk about increased pressure within the bounds of that compartment, and that's the internal pressure versus the blood pressure. Okay, and what that's getting at, the internal pressure versus the blood pressure, is that that's how we decide sometimes what the delta is. You guys know what I mean by delta is? What the change is, correct? Okay. All right. I'll get to my rant in a second about those numbers, but just what I need you guys to understand is when I talk about compartment syndrome, I'm talking about lower extremity compartment syndrome only for the purpose of this course. Does it also, is it more common in lower compartment? Yes. That's why it's important for you guys to know, okay? But does it also occur in anywhere that there's a compartment that has those components in it? It does, right? So you can have forearms, right? You can have feet, right? You can have thighs, right? But more commonly, when we think about compartment syndrome and the way we teach it, and what you may experience in your practice is lower extremity, okay? But again, most commonly it's in the lower leg and the forearm. We won't even get into the forearm. Am I going to ask you what muscles are in each compartment on the lower extremity? Pause. Okay. I want you to know that there are 4 compartments in the lower extremity that of concern. That's the anterior, the lateral, the superficial posterior, and the deep posterior. That's what I want you to know. Okay? Because I'm not going to give you a question that's 5 pages long to tell you exactly which part of the muscle I'm talking about so you can figure out which muscle it is. Okay? But I do want you to know those compartments. Are they all labeled there? Yeah, they're all labeled there. Anterior, lateral, superficial posterior, deep posterior. What is the most common cause? Trauma. So this is why you see it in the military. Trauma is anything from combat injuries, right? Crush injuries due to some kind of industrial worksite injury, etc. Okay? Crush or fracture, right? So it's causing bleeding in that compartment, and does that blood have anywhere to go? No, right? So it increases that pressure. Okay? What other things can cause it? Burns, snake bites, reperfusion syndromes. What's the last one there? So unrelieved pressure necrosis. We won't get too much into those. But see how that's labeled acute, right? So this is an important concept I want you guys to leave here with today. When we're talking about acute and we're talking about trauma, that means they just had trauma. They just had a crush injury. They just sustained a fracture, or relatively within that time frame. If they come to you and they say, hey, I've been having these symptoms on and off when I run. Usually about a minute into my run, I start getting this tingling sensation. My foot feels like I can't lift it up all the way off the ground eventually. But when I stop running, it goes away. Is that acute compartment syndrome or chronic compartment syndrome? Chronic, right? So that's why it's important when you guys are looking at the clinical vignette and you're being given a scenario that you guys pick that out from the scenario. Right? I will tell you straight up front. This patient has sustained a crush injury 2 hours prior, 30 minutes prior to transport. And now they present with these symptoms. So therefore, in your mind, you're putting it into acute compartment syndrome, correct? Okay. Any questions about that? So chronic, where are you going to see those? Military, right? I have had everybody from guys straight out of boot to special operators, right, that have been through a pipeline, and they come in and say these symptoms have been present, and now what do I do about it? And it's a difficult decision because surgery for it may take them away from their career field after all that work. But that's not your job. Your job is to figure out, is this acute? Because is that a surgical emergency? And if it's chronic, then you send them to someone like me after you work them up, correct? And we'll talk about the workup. Okay, clinical symptoms. This trips people up every semester because it's taught different ways in different specialties. But the 6 Ps are the same, okay? They are the same. It's just kind of what, from our mindset, when we're going down and we're seeing somebody, are we as concerned about certain Ps versus other Ps? Yes, we are, right? If they're pulseless, that's bad, right? Because that means they have necrosis. Tissue is dying, right? But it does say pain is most specific, okay? Right? So that throws people off. They're like, well, we care about the pain, but we care about the pain in relation to their physical exam, for example, right? Because can somebody have pain if they have sustained a fracture? Yeah, crush injury, all this thing I described, sure. But it's pain out of proportion that's important. Okay, pallor is what? The pale appearance, lack of blood flow. Maybe there's some hemodynamic changes there. Okay, paresthesias, that's numbness and tingling, right? Now, not to get into a subject that we're going to get into next week, but you know, you guys do understand the difference between paresthesia and numbness, right? You're saying yes? Okay, I'll ask you next week and we'll see. But I will tell you that paresthesias are kind of going, coming and going. Numbness is not transient. So understand the difference between those two. I'm not saying you're wrong, sir. You probably do know you're right. Yeah. But because that trips people up. When you guys get into neurology, he may ask you a question you get wrong. Because you don't understand that paresthesia is numbness and tingling. It's intermittent, transient, right? And numbness is permanent. It can be more on a scale of it's more significant pathology, long-standing, or, God forbid, it's permanent. So then, therefore, is numbness a neurologic deficit? That's why it becomes different. Make sense? All right, I'll leave it there. All right, paresis, that's late. That basically means they can't do, you know what? They can't do anything, right? That means the muscle has died, right? Necrosis, we know what that is, right? Tissue necrosis, hyperperfusion, that's bad, right? That's what we're trying to prevent. So why is that one in pulsus in red? Because that means if you walk up on somebody and now they are no longer experiencing pain, because they won't, right? When they get to a point where those nerves become compressed, can they experience pain anymore? No, right? Or at least not the same way. It may be pain on a proportion, for example. You barely even touch that patient, or you manipulate the body part and they scream bloody murder, right? But if they have, which ones? If they have paresis and pulsus, that's a bad sign. That poikilothermia, right? Cool word to say, right? What does that mean? That just means they can have those thermal skin changes. Can they have that just to result in environmental factors? Yes. So I would say that one's one that I don't even really think of, if I'm being honest, right? So maybe somebody was submerged when they got hit by a jet ski. Okay. You know you're out there. All right, but that's for acute, right? For chronic, now we're moving on to no pain 30 minutes after exercise. Okay, again, I'm an exercise physiologist. Do I agree with the 30 minutes? Ask me after class. But by definition, if they have pain when they initiate the physical activity and then they rest, and 30 minutes later their symptoms completely resolved, it is now chronic compartment syndrome. So what is the full term for chronic compartment syndrome? Chronic exertional compartment syndrome. CECS. Am I going to test you on that? No. But if you understand that that's what it actually is, then you understand what it is, right? Does that make sense? So hopefully that's helpful. If it's not, erase it in your mind. Right? But the bad things, basically you have tissue necrosis, right? Muscle death, permanent loss of function. Sir? Is it bad to exercise? It's always good to exercise, sir.
But so like you're not making anything worse. I mean, like it says you feel better, so is it better?
So
Better.
his question is it bad to exercise when you have chronic exertional compartment syndrome? So I will tell you this. When you're talking about chronic exertional compartment syndrome, are you talking about the 6 Ps? No. No. So I'm not trying to put you on the spot. You asked an excellent question because I need to make sure you guys understand the difference. So the scenario will not give you that. So basically, if somebody gets to a point where they are having the 6 Ps, more significant badness has occurred, right? And that leads to that component of acute kidney failure. You guys know what rhabdomyolysis is? That's when it's bad. So your question is not a bad question, right? In 2000 whatever, in 2000 whatever, I was the chief medical officer for School Infantry West, USOC, Camp Pendleton, California, okay? So, do you think when people are going through infantry training, they will tell the Marine, if you can push through training, you will train? Yes, and then they get rhabdo, right? Do you think then you've done a bad thing? Yes, so it wasn't uncommon for us to bring instructors in and say, hey, this patient, this person, right, this Marine, was exhibiting symptoms of the onset of rhabdo, and you made them continue to train. We need to have a discussion about your role in this training course. That's when it's bad. When you don't recognize the signs of it going from something that's just can be relieved by rest, because most patients will self-regulate, right? They'll stop doing whatever it is that's causing them to have that pain. Make sense? Do I run anymore? Only when chased, right? But that's a choice, right? But if you have somebody who's a PJ, I'll use this patient as an example, right? And he says that every time he was having issues with that, I mean, he had foot trauma. Like he couldn't lift it, and I'm like, how did you get through the pipeline? He just found a way. So that's why I'm telling you guys, people, if they're motivated enough, will find a way. Okay? So, did I answer your question? Yeah, hopefully you understand that I was coming at it from a point of, that is a good question, it's just not that simple. You have to understand the factors involved. Make sense? Okay. Good question. All right. Limb loss. Well, yep, you're going to lose it. We're going to hack it. If it ain't viable, we take it. Okay? This is your physical exam finding. Okay? So when we talk about these different compartments, I do want you to know these compartments as far as when you were to come in and do that passive range of motion, if they have symptomology, where is it going to be? And more so for the anterior compartment. That's why it says anterior leg. So everything there in yellow is important. Okay? Or gold bold, excuse me. So that's passive stretch, right? If somebody has compartment syndrome, do you think they're going to want to actively move? No. You're going to go down there. Right? I'm going to come down there. You tell me you've got compartment syndrome, you're working ER. I'm going to come down there, I'm going to grab them by the toe. I'm going to go like, I'm going to keep walking. And I'm going to, as I'm doing that, what am I doing? Stretching. And I'm trying to see, do they have pain? Is it out of proportion? If they're like, I'm like, dude, this ain't compartment syndrome. And by the way, he's been having these symptoms for 2 years, and they only come on with exercise. And now that he's been laying here for, I'll use 30 minutes. He's been laying here for 30 minutes, the symptoms went away completely. I'm like, okay, all right. So I use that, true story by the way. The names have been changed to protect innocent. Or the guilty, okay? So yes, are the other compartments there? They are. Okay, I do think it's important for you to understand those things, right? But you must understand anterior compartment because is that the most common? Followed by lateral, followed by et cetera, right? But the most common is anterior compartment. So somebody's writing down, only memorize half this slide. That's not what I'm saying. I'm just telling you, you must understand the first half of that slide because you're going to miss things that commonly occur when this compartment syndrome is present. Good to go? Okay. There's some pictures there, right? Okay, this is the thing I'm going to kind of end you guys on today, right? Is this compartment syndrome? And the way this course used to be, the iteration of it, they would test you on the delta, that change, calculating those numbers. I am not a math guy, and I will tell you this too. I'm an exercise physiologist, right? So whatever. But I'm also a speech surgery PA. When I was in the Pacific Rim, I was the only provider, not PA, provider that knew how to do this testing. What does that tell you? Does that mean that this is something you're going to be doing in your primary care clinics without further training? No. And I'm not going to provide you that training. Therefore, I'm not going to test you on deltas. Right? But I do want you to know the absolutes. Not the relatives, right? Because relatives are deltas, but the absolutes. The normal resting pressure is 15 millimeters of mercury. That's what HG stands for, right? Mercury. That's normal, right? And the striker needle is that device there. It is an actual thermometer that has a pre-filled syringe there, right? With saline and a side-ported needle and a digital display there. So that's where you're going to see those numbers. Do you remember how many compartments I said were in the lower extremity? 4. So if you're going to poke this person, you're going to poke them 4 times each time. Is that something you want to be doing willy-nilly? No. Yes. He says yes. Perfect. I'll let them know you're coming. All right. So, but an absolute pressure greater than 30 millimeters of mercury, right? And that's the delta P. Something got cut off there. Delta P. But that's that change in that number. That's what that means. That's a change in the pressure, right? So that's abnormal. Okay. Right. So I want you to know that 15 millimeters of mercury is normal. Okay. And that same thing, is it the same thing if you go down to chronic? Yes. 15 is normal, okay? The difference with chronic is, when you get somebody in clinic, if I have somebody come to me in clinic to get testing for chronic, right? To see if they actually have exertional performance syndrome, do you think I poked them before they ran? Yes. And when after they ran, when they're all hot and sweaty running into my setup area? Yes. And then what? A minute later, I poke them again 4 times? Yes. And then what? 5 minutes later, I poke them again? Yes. Do I want you to know all those deltas? No. The answer is no in this case. But I do want you to understand that 15 millimeters of mercury is normal. Because if you are in a deployed environment, you happen to have a striker needle, right? They're not even called that anymore, but they're still taught that way. But whatever device you have, it's equivalent. And you're thinking you have compartment syndrome, do you need to waste time doing a compartment pressure check? No, right? Because you have all the P's, you have the pre-existing trauma, and you have signs of impending tissue necrosis. We don't even waste our time with that. Does that make sense? Only in the case of acute, if it's equivocal, or usually if you're an ER guy who just wants to stab people, or you do that, right? Because the diagnosis makes itself. As a surgery guy, like I said before, you call me on the phone, Smith, you tell me you're working in the ER, right? Yes. Yes. And then, so you call me and say you think that compartment syndrome, I'm going to say, okay, do me a favor. A bottle of whatever you got, Ibiclens, betadine, right, by the bedside, a scalpel taped to the head of the bed, I'll be right there. Because if you tell me you have compartment syndrome, I need to get after it right away. And which compartments do you think I'm going to release? All of them. Anterior, lateral, and deep posterior, superficial posterior. I'm slicing and dicing. How many times did I do that in a full environment? A lot. But that's different, right? You know, you have blast injuries. You have people that have sustained significant mechanisms of injury, right? In the civilian world, again, they have to have that history and that presentation. Good to go? Does that look like fun to you guys? Apparently to that guy over there. So, all right, sir. We need. Yeah.
So a lot of people try to do like how do they avoid?
Okay, so you're saying if they have a diagnosis of chronic exertional compartment syndrome, how do they avoid getting testing?
No, like how do you avoid? Because people still do these long distance activities.
Perfect. All right, so his question is, how do you, if you have chronic exertional compartment syndrome, right, you have the symptoms, maybe not necessarily the diagnosis, right? And how do you keep going? And I told you, motivation. Some people are just motivated, okay? But the other thing is, if you look at the treatment here, the way that you treat these things for chronic exertional is to take a look at things that are non-operative in nature. Maybe the way they run is weird. Maybe they have some kind of foot deformity that's causing them to heel strike differently or strike their foot differently. Maybe they have tight calf muscles, things like that, right? Because do you think we slice and dice on everybody that's chronic exertional? No, because we tell them, what do you think the treatment is for chronic exertional?
Stop running.
It's the same as acute per se, right? We're slicing, but it's just done in a more controlled fashion. We're actually taking consideration of the nerves, by making sure we're not getting into badness. Does that make sense? So did I answer your question at some point? How do people keep going? Yeah, so PJ came to me and I said, listen, if I do this testing on you, and you meet the criteria, because remember this criteria, 1 minute post, 5 minutes post, I use that criteria, and I offer you surgery, and you get the surgery, that will end your ability to be a PJ. And he looked at me and he said, good to go, sir, nice to meet you, never saw the guy again. Right? So some people just choose to find a way. Did I send him to physical therapy? Those guys have physical therapists embedded with them, okay? They're on the tactical side, okay? But he found a way. So if you make it back to me and you have chronic, that means you've decided, hey, I'm willing to undergo the multiple stabbings and to make the diagnosis and then come up with a surgical indication. Did I answer your question? So the fasciotomy, again, if it's acute, it's emergent fasciotomy. Chronic, it's fasciotomy. It's a non-operative treatment failure. Again, you send them for chronic retraining, all those things. I apologize, I'm a little behind. Well, what are the adverse outcomes? Do people worry about the scars if they're acute? Not normally. They'd rather keep the leg. But if they are chronic, I tell them, you're going to have these big, honking, nasty scars, right? Do those take time to heal sometimes? Yeah, for chronic, they do. They look kind of, we just gotta watch them for a while, right? And say, I hope they heal. That looks like it's healing, So, do we tell them like they don't wear tight socks anymore and boots, the blouse? Yes. So there's considerations there to try to get it to heal. Okay. All right. Acute. All acute comes to me. All acute goes to ortho. Period. At least the ER, because they will know when to call us or do what they got to do. Bedside fasciotomies are a thing. If you can, get them to the emergency room, but time is tissue. You must do the releases as soon as necessary. Okay? For chronic, it's only if the non-operative stuff fails. PT is a good way to start. Physical therapy, you got somebody who's like a running guru, send it to them. Okay? Figure out what sport they do. Try to gear your treatment around that. Okay? Good to go? I'm going to stop there. I'm like 3 minutes behind. I apologize. But he asked a really good question. Have a good day.